So this is Allison Chilton, and this is my Case Connections video presentation for Unit 4. So the first case I decided to discuss was case number 1. This is the case where there is a newborn girl who's a normal at birth, but within 24 hours, she develops lethargy, hypothermia, and apnea. The physician suspects a metabolic disorder and orders a panel of labs. The first question we're asked is what would be the best diagnostic tool to use to differentiate between a urea cycle disorder or a beta oxidation disorder. And the options we're given are blood glucose, urinary acids, serum fatty acids, or plasma glutamine. So the best choice in this instance to distinguish between the two disorders would be plasma glutamine. The reason for this is that in patients with urea cycle disorders, there's a defect in one of the enzymes required for protein degradation. So patients with these disorders will usually have elevated levels of ammonia and amino acids in their plasma, one of which would be glutamine. Patients with disorders in beta oxidation are unable to perform ketosis under fasted conditions and would typically present with hypoglycemia, but there would be no reason for there to be any elevated glutamine or amino acids in their plasma. So by doing this test, you'd be able to see that a patient with elevated plasma glutamine would most likely have a urea cycle disorder, whereas a patient with a normal level would more likely have a beta oxidation disorder. So the next part of the case study, some blood workups are done, and then we're given the results from that. And this patient has an initial elevated ammonia level, far above the normal range. They also have an elevated number of orotic acid in their urine, very far above the normal range as well. And it shows that their plasma citrulline level is slightly lower than normal. We are then asked that based on the elevation of the orotic acid in the urine, what's the most likely enzyme in which this patient has a deficiency in the urea cycle, and what's the least likely enzyme? So based on the elevated levels of orotic acid, the most likely enzyme that's deficient in this patient would be OTC. And the reason for this is that OTC is responsible for the reaction that converts carbamoyl phosphate to citrulline. So when this enzyme is deficient, carbamoyl phosphate builds up because it's not being converted to citrulline and is instead converted to orotic acid. So in patients where this enzyme is deficient, you typically see elevated levels of orotic acid. The least likely enzyme to be the one that is deficient in this case would be CPS1. And the reason for this is that CPS1 is the enzyme that's responsible for converting N-acetylglutamate to carbamoyl phosphate. So if this enzyme was deficient, carbamoyl phosphate would not be being produced, and therefore we would not see any elevated levels of orotic acid in patients with that enzyme deficiency. So the next case I decided to discuss was case number 2. And this is the case where we're introduced to patient A, who is a 4-day-old baby. She had a normal birth, but her newborn screening shows elevated levels of phenylalanine. So the doctor initially has a presumptive diagnosis of phenylketonuria and orders that further samples are taken to determine if this is correct. The parents are asked about their family history, and they both say that there is no history of phenylketonuria in the family. So the first thing that we're asked is, as a consequence of this presentation, which would be phenylketonuria, what amino acid would become essential in a patient with that disorder? So in phenylketonuria, there's a deficiency in the gene that codes for phenylalanine hydroxylase. And this is the enzyme that converts phenylalanine to tyrosine. So patients with this disorder would be lacking tyrosine in their body and would require to get more from their diet or through a supplement. So that would be the amino acid that would become essential in this disorder. Then the next part of the case study says, what are the potential causes of the presentation of phenylketonuria? So phenylketonuria is an inherited disease, which is usually carried on the recessive gene. So in order for a child to have this disorder, they would need to inherit the mutated gene from both of their parents. So they would have 2 mutated genes in order for this disorder to be present. Since the parents both said that there was no history and that they weren't suffering from this disorder, it could be assumed that each parent had a dominant normal gene with a recessive mutated gene, and that they both passed their recessive gene down to their child, which would explain why the child had phenylketonuria. Going on in the case study, we were introduced to a second patient, patient B, who is also suspected of having PKU. So both of these patients are given a BH4 load, and then we're given the results from that loading test in a graph. The graph shows that in patient B, after the BH4 loading, their phenylalanine levels drop down significantly. In patient A, after the BH4 loading, their phenylalanine levels actually rose slightly. And we're asked to interpret these results and what it means for each patient. So based on the results, it can be seen that in patient B, they most likely do not have phenylketonuria, but instead have a deficiency in BH4. So BH4 is the coenzyme that is essential in the reaction of phenylalanine hydroxylase converting phenylalanine to tyrosine. So in this patient, once they were given BH4, their phenylalanine hydroxylase worked properly and the phenylalanine was converted to tyrosine, meaning that they wouldn't have phenylketonuria because there's no issue with that enzyme. It was just the coenzyme needed from the BH4 coenzyme needed. In patient A, it can be determined that they do have phenylketonuria because even when the BH4 was administered, their enzyme of the phenylalanine hydroxylase was still not working properly and the phenylalanine was not being converted to tyrosine. Thank you.